When we get ready for the head and neck exam, one of the things that I always try to introduce the students to is that you're going to have been working with this patient probably a good 45 minutes to an hour before you even get to this point. During that time frame, if you look at the top of the sheet, you'll have made some determination of your general appraisal. There will be things that will show up in the health history that may be very obvious. Let's say maybe, well, or maybe not so obvious. Maybe their history of diabetes, but they've had a leg amputation, and maybe they didn't mark down leg amputation. So something about, you'll make a statement up there that may say healthy 29-year-old male, or you may have something like 69-year-old male with right leg amputation due to diabetes, something that has effect to their overall appraisal that may not show up on that medical history form or is not well defined there. So that would be things like their gait, if they appear to be nervous, things like that. And Ms. Pierce will talk with you about how she wants that documented. But you'll have spent a good bit of time to the side and to the front of the chair and had a good opportunity to do a lot of that general appraisal information, including facial form, maybe how the eyes are reacting to light. For example, you may have one pupil that's dilated and one that's not. So you'll have a good bit of opportunity to gather that information before we even get to this point. I've explained to the patient that I'm going to do an evaluation, a head and neck cancer screening, that we do find about, right now, they're finding 30,000 new oral cancer cases per year, and that's actually a good thing, because like any cancer, the earlier that you find it and detect it, the much easier it can be treated. Oral cancer, the majority of oral cancers are very treatable, and the whole idea is early detection. So what I tell our patients is that we're going to evaluate, we've picked major lymph node chains that drain the head and neck area, major muscle groups, and joints and glands of the head and neck area that we're evaluating for anything that's uncomfortable, any lumps, bumps, anything that is out of the ordinary and not symmetrical. So I'm going to let Pat know that I'm going to be evaluating these structures, and we'll set up a couple guidelines. One, if anything's uncomfortable, I need her to let me know. In some way she can either raise her hand, or if I'm not speaking loud enough and she can't hear me, to raise her hand. That I'll usually say something like lymph nodes typically are a part of our drainage system of our head and neck area that deal with irritants and infection. And the lymph nodes will typically be, they're kind of like bean shaped, and they're typically like a flat balloon. When we notice them is when they're enlarged a little bit. Other than that, she won't probably notice anything. And you'll notice that I'm already in my gown. I know that when I go to my intraoral, and when I go from there, odds are I'm going to be using air water syringe as I move into doing my dental charting and things. So it makes sense for me to go ahead and put my personal protection equipment on. It just makes the flow from one step to the next easier once I start working intraorally. And with me, because my glasses aren't sufficient enough to serve as safety eyewear, then I wear my shield. So I just immediately go into my full wear. Because when I'm doing some of the activities where I'm right in front of her, if she sneezes or coughs, or vice versa, we're going to expose each other. So that's when I'll usually tell the patient something about, if I don't speak loud enough, let me know, because with my shield it'll muffle things. Now at this point, if Pat has any kind of removable appliances, I actually want them to stay in her mouth during the procedure. However, with her glasses, I'm going to ask her to take her glasses off and just hold them in her lap while we do the extraoral. And when you look at your sheet that you're going to document on, always think about all the W's: who, what, why, when, where. If I find any kind of or have any kind of finding, I want to know how long it's been there, if the patient has noticed it, if it's tender, size, shape, color, everything I can describe in written format so that if someone had to come in behind me and I wasn't here, they could find, locate, and evaluate that whatever the structure or lesion I'm looking at. The other thing with head and neck exam is you try to establish some sort of sequence, mostly so that you don't forget structures. It's not like you're bound to that sequence, but you want something that makes sense, that's time efficient, and helps you remember the structures. So I'm going to start with the occipital nodes, and the occipital nodes basically follow the shape of the occipital bone, but since you can't necessarily tell where that is, what they tell you to do is to do a palpation technique below the hairline, at the hairline, and above the hairline. Then that way you'll have covered your area. So I'm going to have Pat lean forward just a little bit, and I'm going to use bimanual technique with a circular palpation technique, because what I'm trying to do is evaluate if any lymph nodes are enlarged. Typically, lymph nodes are basically a kind of a kidney bean shaped filtering system that normally you and I cannot feel. We would not be able to locate them unless they're slightly enlarged or have swollen a little bit or gotten a little hardened. Typically they're like a flat balloon unless they're enlarged, and then that's when we find them. But we have to find them by trapping them against hard structures like the skull, our hands, something like that, because if we just press the tissue, they'll move away from us. So I'm going to start back here. I'm going to start in the middle and basically work myself out toward the sternocleidoid mastoid muscle, or basically at the edge of the ear. So I've done one stripe under her hairline, one at her hairline. And she's having to put a little pressure because I'm pushing on her and she's having to push back a little bit. Then when I get in this area, it's just great. I can do my postauricular. I'm going to come up around her ears. And I can come forward and I can do my preauricular. And then we have our parotid right in this area. Okay? And I also want to make sure, especially if there's folks that are out in the sun a lot, I want to make sure I check the whole helix area of the ear. I want to check all my cartilage. She has a little bit of skin macules over here, but it's typical with her skin coloring. I want to make sure the tops of the ears get hit hard with cancer here, tops of the nose and the lips with sun-related cancer. So I'm going to come around here, and when I'm in the front here, this is a good place for me to evaluate the temporomandibular joint. And if you watch, Pat, you'll know, in fact, you may even be able to hear it. Have you open for me? And then close down and open again. And what I'm checking for there, and then there's different ways to describe that sound. It's a snapping. I would follow through a series of questions of the who, what, why, when. I would like to know how long has it been doing that? Is it creating any difficulty for her? A series of questions that deals with bruxism. And we already know she wears a night guard at night, but if she's having pain in her joint, if she's having headaches, teeth that are sensitive to cold, that kind of thing. Aside from the noise that you're hearing there, what I'm looking for, have you open again for me, is I want to see also if we have a nice smooth opening along the midline. Then I'm going to have her move side to side and lateral, and then forward like a bulldog. And I want to check protrusive and lateral motions to see if we have any extra noises there. I also want to see if her range of motion is appropriate for her body and her proportion to her size. And so what I'm going to ask Pat to do, and sometimes you have to kind of do the motions to do this, I want her to take her first 3 fingers like this, and I want her to place them inside her mouth. Good, and that's an appropriate range of motion for her. Thank you. Her hand is proportioned to her body size, whereas my hand may or may not. And so I want to make sure I have appropriate range of motion, not overextended or not restricted. And you'll get, after a while, you can do that without having to have the patient do that. You get where you know what the normal range should be. But that's a very appropriate way to do it because of the way the patients are designed with their own body relations. So basically I've done my come up here to the joint, so I'm right up in this area. So I have my temporalis muscle. Have you clench for me? And relax. Her master, clench, and and relax. I'm looking for symmetry again. If I have a real extreme bruxism, I may have one muscle that's been worked harder than the other and will be more enlarged. And I'm in this area, and so I'm going to take my series of my nodes. I'm going to start with, again, bimanual, but I'm using a circular compression, or I should say bilateral. I'm going to come out like this, and then my hand's I'm going to get almost in the middle of the palm of my hand because I want to evaluate this whole product gland all the way out here to the edge of her facial lymph nodes. Okay? And then when I'm there, I can go right here. You have your submental, and again, the lymph nodes will actually follow in on the inferior part of the mandible, both our submandibular and our submental. And so what I'm doing is I'm actually taking that tissue, pulling it up over the mandible, and letting it relax against my fingers. If the lymph nodes were enlarged, that's when I would feel them, is when they'd roll back against my fingers. I'm not noticing any here in the submental area. Have you lower your head for me a little bit? In fact, what I just did is, your patients will tend to want to sit very nice and straight for you. When I get ready to do the submandibular area, I actually need that tissue to not be so tense, and I need her to actually bring her head down just a little bit. And so what I'm going to do is I'm going to use this hand to actually loosen this tissue up and push it over to this side, because we'll have a whole series of submandibular lymph nodes that are going to follow along the border of the mandible, and they'll actually be inferior. So what I'm doing is I'm taking that tissue, I'm stretching it out over the mandible, and I let it relax back with my fingers underneath, and if there are any enlarged lymph nodes, I'll feel them as they move back. Have you lowered just a little bit? Good. She has one right here, back in the anterior third. Is that tender when I? Okay, you can feel it kind of pop.
Yeah.
So later we'll let you all feel what that feels like. So what I want to know about that is, I'm basically going to note that it's asymptomatic. She doesn't know that it's there. It's movable. It's non-tender. It's probably about the size of, maybe a piece of macaroni. It's back in the anterior third of the left side of the mandible. And we keep track of that. Very common, because all these lymph nodes are draining the head neck area and the sinus area. Very common here in Austin because of high allergen counts to have enlarged submandibular lymph nodes. Then I do basically the same thing on the other side. I'm going to make this tissue move over to this side. And people tend to be bilateral, but not always. In fact, there's one right over here. It's a large one right there. Similar, are any of those tender? Do you tend to have some allergy issues?
Yes.
Okay, so that matches. Now, what did I read? Something like 35% of cancers will exhibit lymphadenopathy prior to advancing in different stages of metastasis. So that's one of the reasons why we need to document that. Lymphadenopathy just means an enlarged swollen lymph node, and we keep track of it. So we've gone down along here. Now you also have submandibular glands in here, and to evaluate those, I'm going to have her put her tongue up to the roof of the mouth, and then I'm just going to use some upward motion, pressure, to feel any lumps or bumps or tenderness as she's doing that. So I need that floor of the mouth kind of tense to do that. And have you relax. So basically we've come from here down, and now we're into the neck region. So again, I'm going to have Pat just lower her head for me a little bit, and then just turn away from me. I'm going to bring you back to the middle again here, and come down and turn. There you go. We're going to do it one more time because I want to get this muscle to show up really well. Bring your chin up just a little bit. Okay, now just turn straight through. Her muscle doesn't pop out like I'd like it to, so let's try one more time. And lower just a little bit, and just turn. No, it just doesn't pop out. Sometimes it'll pop out real prominent. So what you have to remember is I'm looking for the sternocleidoid mastoid muscle. So you're going to basically go from the base of the ear, and it's going to come down, and you have a triangular space here. Back here's your trapezius. Lots of lymph nodes. Now you have deep cervical. You're not going to feel those, but you'll have lymph nodes that are going to go along the muscle, and in front of the muscle you have jugular lymph nodes in there. So what I want to do is locate the muscle And the first thing I'm going to do is just palpate that muscle down to its attachment. Okay? And then, knowing that the lymph nodes kind of go around the muscle in a circular fashion, same sort of thing, I want to see if I'm trapping any lymph nodes, and I'll watch to see or feel any lymph nodes. Again, a lot of times just extending the neck, the lymph node will pop up a little bit. Then I'm going to palpate at the triangular area behind the muscle and the area in front of the muscle. And then while she's there, and I will inform her before I do this that I need to be around her collar area here. Since I'm over here, you have your sternocleidoid mastoid that comes down to your clavicular area. So you have a whole bunch of lymph nodes that are right here along your clavicle. Okay? And then I'm going to do basically the same thing on the opposite side. So I'm going to have you turn over toward Rajan. And I'm supporting her head over here because sometimes, patients, they're going to feel like their head's floating out there and they really don't know what you want them to do. And then again down here along the collarbone area. Okay. Anything uncomfortable there at all? Okay, so that brings me to the rest of the neck area. And the big thing we're looking there for, just like we are elsewhere, symmetry. And we want to make sure thyroid cancer is actually fairly common, and the thyroid gland can sometimes bind down to the cartilage in the larynx area. So what I'm going to do here is to get some perception of where symmetry is, I'm going to find her muscles, put my fingers on either side to see if basically I have equal distance if she were located at the midline. Then one of the things I'm going to have her do is go ahead and swallow for me, because her larynx should go up and down as she swallows. Then I'm going to warn her that this might feel a little gravelly even. I'm going to take the cartilage and I want it to be mobile. It should move across the trachea. And then I'm going to check for any hardening or any swelling in this area of the thyroid gland. Okay. Take a look for me, see if we missed anything. Now, as far as facial form, again, you would have done a lot of this at your initial evaluation when you're seated with the patient, but I want to make sure, and I'll inform the patients I'm going to pick up their hair. Now, she has a little nevi, little mole, raised area up here. She has some, you could either call them freckles or small macules. And so the big thing I want to know from her is if she's noticed any change in size or color or shape with the little mole that she has on her forehead. Yes? No? No. But I want to have some sort of questioning because melanoma is a common cancer and we need to really keep an eye on it. And then we educate the patient as to the signs and symptoms of melanoma. And then again, I'm going to look for symmetry, any signs of scarring, or someone may have, especially if someone wears glasses, they could have basal cell carcinoma along this bridge area of their nose, may not even know it until they take their glasses off. And while I'm here too, I'm also looking at the lip area. Okay. Then I tell the patient we're going from doing what's outside, now I'm going to evaluate what's inside their mouth. I don't want to carry whatever I had on the gloves from the extraoral into the intraoral. And then I can have Pat go ahead and put her glasses back on. And we'll just use her glasses as her protective eyewear. And the fact that I already have my shield on and everything just makes it an easy transition instead of having to go and remember to putting on your shield and going from there. And then I'm going to bring this lady back. real similar when I have Pat reclined. Again, I'm going to be looking at skin. I want to look at extraoral with the lips. Are they chapped, dry? Do I want a really nice defined lip liner line, if you will? Cancer of the lip, a lot of times will show up where there's a diffuse area or you can't see a real defined line. So you want to and you want to see if when she closes, do her lips come together? So I'll check that. That could be part of the extraoral as I'm going into my intraoral. And then one of the first things I'll do, you'll have had a faculty member that's done a cursory intraoral for you before you've even started. They'll have looked around. If this is the first time you've worked with someone, then have you open for me? Then you're going to want to take just a good overall look intraorally and make sure there's nothing there that's going to create any problems for her or for you as well. So I'm just taking just a good overall cursory look. And then with that, I'm going to start my evaluation. And the first thing I'll do is a lot of times I'm going to take my tissue here from my maxilla. I want to look along the tissue colors, as far as my alveolar mucosa and my attached gingiva. Now I'm going to do a bidigital technique where I'm starting in the midline, and I'm just going to palpate the tissue. So basically I tell the patient, now I'm evaluating that parotid gland only from the inside. And I'm going to evaluate both sides. And you'll notice I'm kind of keeping track of which fingers are wet and which fingers are dry. Because as I come down here, same thing, I want to take a look at the tissues. I start in the midline, work my way out. Good. And then I want to make sure, as I don't want to get moisture all over her face. Okay. Now I'll typically go from there where I'll have looked intraorally. Then I'm going to typically go around and check the tongue area. So the first thing I'll do is I'll tell the patient just to relax their tongue, and I'm going to do a bimanual technique. If I had any, let's say a salivary stone or any kind of enlargement in that area, my goal is to try and trap it between the two fingers. If I just take one finger from the intraoral and push, the tissue will just move away from me. So somehow I have to trap it between the two fingers. So you ask your patient to relax their tongue because this is not a very comfortable thing to have done. But it's a high-risk area, so you want to make sure you evaluate it really well, the whole horseshoe shape of the underside of the tongue. You doing okay? Mm-hmm. Okay. And then when I get ready to evaluate her tongue, sometimes having a dry gauze is not very comfortable, so you want to dampen your gauze a little bit. When I'm having Pat check with having her touch to the roof of her mouth, what I'm looking for is if that frenum attachment is short, next thing I look for is to see if there's been any movement of the attached gingiva and the lingual of these lower anteriors, or if there's any kind of a speech impediment. If not, then that's just something I keep in mind when I get ready to take radiographs or whatnot, that I may have to make adjustments accordingly. Okay. I'm going to get back down here and I want to make sure I do a good look at the vestibule, the tissues in this area, our retromolar pads, and our tuberosities. And especially in my indirect vision areas, like this upper left, I can't see this unless I use my mirror. Mirror and a little light would be helpful. There we go. I'm taking an overall evaluation of the palate area. She does have a raised area down the middle of her palate, so I want to make sure I palpate it. And by definition, it's a maxillary tori or palatine torus. By definition, it runs down the median raphe. And I would describe the size or length, and it basically runs from the middle to the posterior third. And what I'm doing now is I'm palpating the roof of the mouth. I want it to be nice and firm. Try not to press, because that can be uncomfortable to your patient. So I've taken a peek there at that area. Then I'm going to have her go ahead and say "ah" for me. And I'm looking at the tonsillar pillar areas. How do we do "ah" again? The uvula the back of the throat. I mean, we're not ear, nose, and throat folks, but we need to check that whole soft tissue complex, that arch back there, the back of the throat, and she can do it fairly well. Some folks, you have to ask them to kind of act like they're yawning to do back in that area. Okay, if you look at your sheet, I should be, let me know if I've missed anything, I should be at my occlusal classification. And I'll do that, and then we'll talk a little bit about the salivary glands. So how I do my occlusal classification is you need to consider that that part of your chart is showing your maxillary and your mandibular arch in relationship. When you get to charting existing conditions, then you're dealing with teeth individually. So think about this. You're describing how the maxillary arch and the mandibular arch are coming together. So you're going to use angles classification. Have you close down, bite on the back teeth? So I'm going to evaluate the molar relationship on both my right and left side. If one or more of my molars are missing, first molars, then I'm going to go to my canine relationship. So I'll evaluate my occlusal classification on both the right and left side. And then, have you bite again? I'm going to look at how my maxilla relates to my mandible in my anterior area. I'm going to look for overbite, whether it's slight, moderate, or severe. I'm going to look for overjet. And then I'll evaluate everything in general for any kind of crossbite or some malrelation between the two arches. If a tooth is turned, that's torsiverted, and it's going to show up on my existing conditions charting. This is going to be more like if I have one tooth that's out of relation with the other arch. The last piece I wanted to throw in there is when we talk about salivary glands, and you probably saw one evaluation of checking the parotid ducts and the salivary carbuncles, the reality is my gloves are not tacky at all. I have plenty of moisture to do what I need to do in Pat's mouth. If I did not, then I'm going to go and start evaluating my salivary glands to see if I have any one that may be blocked or not functioning. And to do that, I'm going to take, especially if I'm going to my parotid glands first, is I'm going to find my parotid papilla. I'll locate it. I'm going to tell her that I'm going to basically dry that area off. So I'm going to use a little bit of gauze. And then I'll use something to stimulate some salivary flow. So sometimes you tell them to think about sour things. Sometimes just the manipulation with the cotton tip applicator is enough. So I'll evaluate both my parotid glands on either side, my ducts, my Stenson's ducts, and then you have your submandibular glands and your salivary carbuncles in your lower, and all your minor glands in the floor of the mouth.